Giovanni is a physiotherapist. He is a National Health and Medical Research Council Emerging Leadership Fellow at the Sydney Musculoskeletal Health at the University of Sydney in Australia. Giovanni's research interests include investigating the efficacy and effectiveness of commonly used but poorly investigated treatments for low back pain and how different communication and education strategies shape clinical decision and outcomes in people with low back pain. So I give you Giovanni.
Thanks, Adam. Hi, everyone. Let's talk a little bit about labels and back pain. So today I'm going to be talking about diagnostic labels. So just to clarify what I mean by that, it is the term used to communicate a diagnosis to a person. There's going to be a lot of slides here where I'm going to be talking about diagnosis and diagnostic labels. They're not exactly the same thing, but labels are how we communicate that diagnosis to a patient. I mean, the process of diagnosis is the cornerstone of medicine, right? You need to reach a diagnosis for you to be able to understand the severity of the disease, for you to be able to stage the person's condition, to think about treatments that will be matched to that condition, which will hopefully lead to better outcomes. That's what happens in pretty much the whole of medicine, but in musculoskeletal pain and back pain, it seems to be a little bit challenging at times. There's some instances where diagnosis isn't necessarily helpful, and I'll run through some examples. So if you look at this figure there, you can see that when in South Korea, ultrasounds were introduced to assess the thyroid, the incidence of new diagnosis of thyroid cancer went through the roof in the green line. I presume it's green. I'm colorblind, so I'm assuming it's green. But you can also see that the death rates remain constant, which means a lot of new diagnoses were made, but it didn't have an important impact on the outcome that matters, which is death. So is that extra diagnosis, are those extra diagnoses really helpful? Maybe not. There's some discussion around that. There's some other ways where diagnosis might not be necessarily helpful, and that happens a lot when in healthcare diseases have their definitions expanded, and that can be done via creating new categories of pre-disease. That happens a lot, pre-diabetes, pre-high blood pressure. In instances where diagnostic thresholds are lowered, and that happens a lot as well, or when a new test with the promise of providing earlier diagnosis goes into the market without a full assessment of its accuracy and validity. Now, thinking about back pain and how complex that is, back to our diagnosis diagram here. Obviously, when you have a patient with back pain in front of you, you rely on your ability to take proper history and conduct a physical examination that's as thorough as possible. But those elements can be tricky sometimes for you to be able to use them to come up with a diagnosis, because a lot of those things that we do with the patient in front of us, they're not necessarily really valid to inform a diagnosis at the end of the consultation. You can then think about doing diagnostic testing, but we know that a lot of features, for example, a lot of imaging features, for example, they're not very informative because they are very commonly present in people who are asymptomatic but do have those features on their scans as well. So that brings us to a problem, which is how do we diagnose back pain appropriately and validly? And I do want to point out that we may be able to diagnose certain types of back pain, and we had a bit of discussion about that yesterday. Just a few weeks ago, this interesting study came out showing that, yes, there are informative tests that can be used to diagnose some specific types of back pain. So, for example, sources of back pain. So, for example, the disc, sacroiliac joint, and facet joint pain potentially able to be diagnosed by certain tests. But then my question to you, and maybe for a bit of reflection then, is what's the purpose of that diagnosis? Are we, by doing a diagnosis, by coming up with a diagnosis, are we going to be able to is that going to lead to a better understanding of the patient prognosis? We do know what the prognosis of acute and persistent non-specific back pain, as generic as that can be, is, right? So usually patients fit within that description of prognosis. Will having a more accurate diagnosis lead to a more accurate, will lead to you placing your patient in a more accurate pathway in terms of prognosis? So that's an important question to ask when thinking about, is this diagnosis going to make a difference to the patient or not? Then the second question is, will the diagnosis lead to better treatments? And I'll just use one example here, which is facet joint pain. Will having that diagnosis lead to a better treatment for that condition? And obviously, when you arrive at a specific diagnosis, there's options of matched treatments that you can use that are specifically designed for that particular diagnosis. And I can think about, when thinking about facet joint pain, the thing that comes to mind immediately is radiofrequency ablation. But ablation has been struggling in trials to outperform placebo a lot of the times. And the best data that we have comparing ablation to a structured exercise program like in the MINT trials in the Netherlands show that it doesn't outperform exercise. And I know that there's been a lot of criticisms around the validity of the findings of that trial, but it's sort of the best data that we have so far. So in this particular case, is knowing a specific diagnosis leading to better patient outcomes? The data says that, especially specifically with regards to this particular treatment, I think it's a bit unsure and uncertain. So the first take-home message for today is there's lots of diagnostic labels out there for low back pain. Most are not really informative. And although some may represent a valid diagnosis, I think the questions are important to be asked. Do they improve our understanding of prognosis and how we communicate prognosis to the patient? And do they give us access to better treatment options? And by better here, I mean evidence-based, effective treatment options. So the question comes, should we rethink how we label low back pain to patients? And obviously, when we talk about labels, I think it's pretty clear that there is a lot of tension between what guidelines mention and what happens in clinical practice. If you look at guidelines, there's a big push towards using non-specific low back pain as a category descriptor for most back pain, because there is because most back pain is difficult to be attributed to a specific nociceptive source. At the same time, on the other hand, in clinical practice, a lot of clinicians think it's possible to identify the source of back pain and use that to tailor treatment accordingly. And as a consequence of that, several structural labels, which tend to describe the biological cause of back pain, are then used. And obviously, there's a lot of criticisms of both approaches. If you look at the criticisms of non-specific low back pain, I quite like this criticism from the North American Spine Society, because they do recognize that it is difficult to diagnose back pain. It's very hard to attribute a structural cause to back pain. But at the same time, they mention that the term non-specific back pain provides no biological basis to the problem, which is a big issue in my opinion. And it doesn't help clinicians make decisions. It doesn't help anyone do anything at all. And I agree with that. I think it's a very important point to be made. On the other hand, people who criticize the use of structural labels, there's a lot of debate around the clinical relevance of using those terms to describe back pain to patients. Because of the validity of the tests that are used to identify that particular structure as the source of pain, because, like I mentioned before, many findings are common in asymptomatic people, and because this particular diagnostic label or these diagnostic labels may not lead to better evidence-based care. And ultimately, these labels, these structural labels, they may influence patient behavior and contribute to poor outcomes. And I would like to draw your attention to this study published a few years ago now by Ben, who's a sports physio from New Zealand. He did this very interesting study where he did a qualitative study with people with back pain, and he investigated the enduring impact of what clinicians say to people with back pain. And this think this quote represents very well the point that I'm trying to make here today. So this person, I think it's a man, he injured his back and he was given a label, a slip disc. And together with that particular label, he was given a bit of education, a bit of explanation of how how his condition was going to progress and what was going to happen with him in the future, since, because he had developed that slipped disc problem. And that led to a behavior that influenced the patient's behavior. And the patient says, now I connect any pain that I feel around there to that. So there is a clear influence of how the diagnosis was communicated to the patient and how an explanation about the future related to that diagnosis was, and that had an influence on the patient's behavior. But up until very recently, a lot of the discussions around the impact of diagnostic labels that have been mostly coming from qualitative studies like Ben's study and some anecdotal evidence from clinicians and discussions amongst colleagues. But our team, we decided to investigate that a little bit further. So we did a few experiments, we did a few studies trying to look into the effects of labeling people with certain conditions, giving people certain labels for their back pain, and investigating their management intentions and other outcomes as well. And I'm going to present findings from 2 of those studies to you now. So we enrolled a sample of people with back pain who had and had not sought treatment in the past, and also people who had never experienced back pain in their lifetime. And the reason we did that is because back pain and labels is so ingrained in our society. Everyone knows about back pain. Everyone knows how to describe back pain in different forms. And we thought it was going to be interesting to hear the perspectives of people who are not necessarily patients. And just to give a little bit of a spoiler, the fact that we had that specific type of sample in our largest sample, that didn't make a lot of difference in our findings. We did investigate if people with pain perceived labels differently than people with no pain, and we didn't find much difference. So we gave people a hypothetical scenario, which was we asked them to imagine that they had just started an episode of back pain 3 days ago. They had some disability, couldn't move, couldn't bend or twist. They eventually decided to go see a health professional. It could be any health professional. This health professional conducted a thorough physical examination, and at the end of this consultation, the clinician provided them with, gave them a label. The label was what we randomized, and we had 6 labels in this study. We had 3 structural labels: disc bulge, degeneration, and arthritis. And the reason why we chose them is because they are structural labels. They're very common in imaging findings, and they potentially carry negative connotations, as previous studies had shown. We also used a label, lumbar sprain, and that's because lumbar sprain, it is included in medical classification systems. It is used by clinicians for low back pain that they can't really attribute a cause, and it's also perceived a little bit different by patients. It's perceived by patients as an injury, not so much as a chronic condition that's going to perpetuate. And we also gave people what guidelines recommend as the label, which is non-specific back pain, and an episode of back pain as a sort of control label, which is a label that has no structural descriptor attached to it. So those 6 labels were included in our study. We also attached explanations, lay explanations to the labels, and I've just put 2 examples on the slide there for you to have a look. So we told people you have a disc bulge, and then the explanation about what a disc bulge was came on. We also provided standard reassurance after the labels. So essentially, this was the health professional telling patients that they didn't think there was nothing wrong going on, and they were advised to resume their activities as soon as they could and go back to work and just live their lives. And this is an important consideration. I'm going to talk a little bit more about the effect of advice on treatment intentions. So we looked at primarily at the outcome of need for imaging. The reason for that is that there is most guidelines now discourage imaging for uncomplicated back pain, unless they're obviously suspicious of serious pathology. We had a range of secondary outcomes, including willingness to undergo surgery, belief in the need for second opinion, perceived seriousness of back pain, recovery expectations, and beliefs about physical activity and work. We also looked at, we had 2 open-ended questions, and we asked people to just express their feelings and thoughts about the label that they'd been given, and whether they thought that that particular label would require any specific treatments or not. So we wanted to see what people thought that label would require in terms of treatment. So these are the main findings of the study, and I apologize, the quality of the figure isn't very good, is it? But you can see here at the top of the figure that the non-structural labels, episode of back pain, lumbar sprain, and non-specific back pain, they consistently outperformed the structural labels in terms of reducing the need for imaging. And this was measured on a 0 to 10 scale. You can see the differences between labels was in the order of 1.8 all the way down to 1.3. So very similar effect estimates between the groups, and very consistent across the different comparisons. We didn't find a difference when we compared structural label to structural label, and when we compared a non-structural label to a non-structural label. And then in terms of the outcome, willingness to undergo surgery, the outcomes were very similar, except that the magnitude of the difference was slightly smaller. But again, the same pattern was observed with non-structural labels, significantly reducing patients' intentions to seek surgery compared to structural labels. And then for the other outcomes, we found that compared to structural labels, lumbar sprain consistently had the lowest perceived need for second opinion. Non-specific back pain had the lowest perceived seriousness compared to those structural labels. And lumbar sprain consistently had the highest perceived recovery expectation. And then in terms of the qualitative questions that we asked people, I'm just going to run through this slightly busy slide, but just to, each of the columns represent a label, so disc bulge, arthritis, degeneration, lumbar sprain, non-specific back pain, and episode of back pain. Numbers are the numbers of participants in each group, and in brackets, that's the percentage of people in relation to the whole sample within each group. So we did find that pain was the most common thing described across most labels. So that's what people thought about when they saw the label. Pain was the most common thing, except for tissue, for degeneration and non-specific back pain, where tissue damage and uncertainty were important, the most common feelings evoked by the labels. We show that feelings of poor prognosis and anxiety and fear were more common for structural labels. So you can see at the top there, about 25 to 28% of people in those 2 labels expressed feelings of anxiety and fear and poor prognosis, whereas for the other non-structural labels, this was in the order of 2-4%, so much smaller in relation to the other labels. In terms of feeling of good prognosis, they were more common in non-structural labels. So again, in the order of 20 to 29% for those 2 labels there, lumbar sprain and non-specific low back pain, compared to a much lower proportion, 4% and 1% in arthritis and degeneration. And importantly, non-specific back pain generated a lot of uncertainty feelings amongst the patients in our study, which I think is a very important finding. So the take-home message too here is that non-structural labels reduced intentions for imaging, surgery, second opinion, and improved recovery expectations. We did see that poor prognosis and anxiety and fear were common feelings associated with structural labels. And lumbar sprain was better than all structural labels and did not generate feelings of uncertainty as non-specific low back pain did. Now, in that quote from the qualitative study that I presented earlier, we had a combination of a label plus poor advice, which generated a maladaptive behavior in that patient, right? We examined the effect of labeling and providing advice in a slightly different population, people with shoulder pain, we had done already some work with investigating different labels for shoulder pain, and we had found that bursitis is perceived by patients as a less threatening label compared to, for example, rotator cuff tears. So we took those two labels, and we also presented people with guideline-based advice or advice that you commonly see online, which is to seek treatment. And we did a 2x2 factorial design in which people were exposed to those those elements in combination or in isolation. And we found that both labeling and advice reduced intentions to seek surgery, and the effects of those two interventions are likely to be additive, which means using one and the other are likely to yield bigger effects than using one in isolation. But we did find as well that the effect of advice was higher, was twice as big actually than just labeling the condition using a less threatening label, which I think to me highlights the importance of not only being mindful about how you label a condition to a patient, but providing proper advice that won't perpetuate feelings of poor prognosis, anxiety, and fear when they're not warranted. So where to from here? I think relabeling back pain is a very simple intervention if it's possible to be done. Obviously, in a situation where a patient with persistent pain who's been in pain for decades, who's been to multiple health professionals, who's been labeled for quite some time now, it might be difficult. That might be seen as dismissive if you're just trying to de-label or to change a label. But labeling is a simple intervention when appropriate. It may improve recovery expectations, willingness to return to work, and reduce fear and anxiety. We obviously need to investigate the acceptability of this approach and of certain labels amongst health professionals, patients, and other stakeholders, like, for example, insurance companies. I think it's an important thing, because in some countries, for you to be able to have your claim paid for, you need to be able to provide a specific medical diagnosis, which often needs an imaging to sort of serve as proof that you do have that condition. And if you think about relabeling back pain in, for example, the workers' compensation setting, where you're trying to reduce fear by changing how the condition is labeled, that you might run into trouble. So we need to investigate how acceptable that would be in those settings. And communication is key, so relabeling and providing appropriate reassurance are likely to have additive effects, like I mentioned before, and it just highlights the importance of providing proper advice to patients. Should we settle for non-specific low back pain as a label? Then I think my answer is absolutely no. I think that's not good. As I mentioned before, I do agree with the North American Spine Society. We must recognize that it's difficult at the moment, to identify what the structural cause is, while also highlighting that the term non-specific back pain provides no biological basis to the problem. It doesn't help clinicians do their job. I think my optimistic perspective and view of the future is that at some point in our lives, hopefully we'll be able to see that, we'll be able to identify people who respond better we'll be able to match and target interventions to certain groups of people. And that can be based upon prognostic characteristics, as we saw yesterday, and we might hear a little bit more about it tomorrow, plus or minus diagnosis. It may be that diagnosis, as we now know, might not be as important for the tailoring of interventions, or it might be that in the near future we might be able to develop interventions that are targeted to specific diagnosis, and that will be highly effective. That'll be a great thing to happen, and I'm hopeful that we're getting there. Thank you.
Thank you, Giovanna, for a great talk. Come and join us. Yeah. Yeah. So, do you have any questions, please?
Thanks a million, Giovanna. Yeah, really good talk. I just was your study used the cohort, well, where you just said they had 3 days of back pain. So the evidence is applicable to an acute episode, but I think the room will probably agree. The majority of people that we see, it's not the acute patients that we see. We know most people just get better, and only 10% of people seek care in relation to their backs, and the majority of people with persistent pain. But my point with or my question really is, what phrase should we use for those? Because I think that the acute sprain one's great, but do you have a phrase we could use rather than non-specific back pain for everybody else?
I think in terms, I agree with you. The study was done with a vignette of someone with acute back pain, and we're doing some work now with patients with acute back pain, and one of the things that we're doing, we're asking them if they have any worries about the condition and what worries them. And a lot of the times we're hearing people talking about diagnosis, talking about structures. I'm afraid that I might have a slip disc or something like that. So I think very early on, some of these worries are there, and if we can tackle them in that population, I think we might be able to avoid a cascade of disaster later on for those people. In terms of the persistent pain, I think it's difficult to, like we discussed yesterday, I don't think it'd be appropriate to use lumbar sprain, for example, because you're implying a mechanism that's acute in its nature, and it might not make sense to patients. And I think we need to do work to eventually agree on a label that's non-threatening, that's non-deceiving, and that's acceptable to clinicians and patients. And it's very important that obviously clinicians are on board with that, and that they think that that label might be appropriate for patients, and it has to make sense to people as well. Because if it doesn't make sense, obviously people will go and seek a second opinion, and they'll find someone who'll tell them that they have this, they have the spine of a 150-year-old person, and that might be a bit of a problem.
Next question.
Hi, Michael Cass, Brighton. Thanks for that talk. It was quite thought-provoking. I certainly agree with your comment at the end that non-specific back pain is not something we should be accepting of. I'd just like to challenge you on your cohorts, though. I think that there was only one of those that was structural, namely disc bulge. I'm just stuck how you can say that arthritis or degeneration is structural when you say that lumbar sprain isn't.
How can I say that arthritis and degeneration are structural?
Yeah. Yes. Unless you're relating them to a specific structure. For instance, if you had their facet joint arthrosis or arthritis, yes, that would be structural.
Yeah.
But the term arthritis and the term degenerative, neither are, in my view, structural.
That's an interesting point. We use those terms assuming that they were referring to structural changes in the lumbar spine, degenerative changes in the lumbar spine, and arthritic changes in the lumbar spine. That's a good point, though.
Yeah, I just think they need to be a bit more specific.
Yeah, that's
Okay.
a really good point. Thank you.
It could well be that you mean disc degeneration, and that would be fitting that label of a structure.
It could, yeah. We weren't specific about a specific type of degeneration, but I guess it could fit under that.
I think, though, that these words are commonly used by patients and often refer quite generally to structural changes in their back. So I'd probably argue that those are seen as structural diagnosis, considering the paradigm that most patients come with about their understanding of back pain.
We did a bit of pilot work with patients. We have actually a patient as an author in the study, but we also did a little bit of work with patients to come up with the labels and the descriptions that we used, and that was certainly part of the discussion as well.
Next question.
Abbas, Bedfordshire. Thank you very much. A really good presentation. But there are still some questions which are unanswered, such as, for example, a patient is coming to you and telling you that they have pain over 20 years. So we should have some kind of maybe chronological order. You can say chronic back pain. We might have to settle for that rather than putting some specific label on it. Similarly, a patient who is coming to you with a road traffic accident, medical legal, for example, practice might see that the lumbar sprain might be maybe more appropriate word and maybe more palatable. So I still think that we might have to settle with back pain because of the non-specific nature of various etiological causes there, which we can't pinpoint with any single imaging or any other test. What do you think about that?
Yeah, thanks for your question. I think it's for your comment. I think it's an important one. And the work that we're doing now, we're seeing so much variation. We're seeing people who are really happy to just receive a structural label. It gives them, I think, a sense of validation of what's happening, what's going on with them. At the same time, some people really struggle when they're giving such labels. So I think a big challenge for the future is to be able to identify what sort of patient is in front of you and how should you communicate that diagnosis and the implications of that diagnosis to the patient in front of you. You might need to talk about the structural label, or you might need to avoid that. And I don't think it's obviously a feeling thing, right? You're looking at the patient in front of you and you have to make a call at some point. How are you going to approach, how are you going to have that conversation? But I think it's moving forward, providing this sort of tailored advice and tailored labeling, perhaps, that might be a way to go.
Thank you.
Just to say in our service, and we run a combined physical and psychological program in keeping with the previous talks. We would certainly look at it from a multifactorial perspective, a biopsychosocial perspective, and certainly looking at different features and multifactorial, and I'd refer to it as multifactorial, chronic back pain, mechanical pain. So we tend to think that the explanation and the individual factors might be more relevant than an individual label right now.
Next question.
This kind of hermeneusis or interpretation of language is kind of part of the human condition, isn't it? And what's so fascinating is that it's the language that implies mechanism and solution that is leading to action. And that's the same, is it not, for clinicians and patients? When we think about the manual therapy world, lots of the techniques of the interventions imply some mechanism, stretching, moving, articulation, strengthening, exercise, all of that stuff. And I just wonder how much some of the public health stuff in Australia, how much is it the clinicians leading to the interpretive framework for the patients, or how much is it, again, the patient's expectations leading the clinicians to use labels that they think is going to lead to action?
I think it could be both ways. I think you made an important comment, and just to go a little bit off track here, we did look at structural labels, but I think you mentioned manual therapy and some of the language that's used there, and I believe that if we did some investigation around the impact of some of the labels that are used in manual therapy and in the description of dysfunctions and impairments and whatnot, that would probably lead to some interesting findings, in the sense that people would be more keen perhaps to have inappropriate treatments. And we see that a lot, people who keep coming back to have their spines adjusted and this and that. So I think we need to look more into that.
Because it has to, in the end, make sense. Although, having said that, I know there's some for really out-of-world treatment, that the experience of treatment trumps the cognitive rationalization of treatment. So if you're having kind of Reiki or something, but you don't believe in healing, the feeling it gives you makes you carry on going, which is slightly different interpretation. It's kind of somatic interpretation rather than a cognitive interpretation.
Yeah. Thank you.
Lisa.
Thank you. Hello, thank you very much for a fascinating talk and for raising this important but can of worms. I just wonder what your thoughts are about keeping it as simple as possible of just saying back pain, because if somebody's talking about a sprain, isn't that something gymnasts get? If somebody else is talking about, well, it's not a sprain, it's lumbago, somebody else is talking about something else. By the time patients have seen multiple professionals, everybody's contradicting each other, and one of the biggest causes of problems is this lack of coherence. And if we can't agree what to call it, can we at least agree it's the back? And could we either talk about spine pain or back pain? And would that be a safer way going forward? I'd love your thoughts on that.
That's an interesting perspective, and I agree. I think I made a comment about it being a problem, for someone who's been to multiple health professionals, and then you try to relabel that person's condition, and that could be a problem. And I think that's absolutely true. And I guess that's a common problem across the board. The issue of variation in everything that we do. You go see 10 physios, the 10 physios will give you 10 different treatments. You go see 10 surgeons, you're going to receive 10 different treatment indications. And I think it's hard to get to the core of the problem and to address that. Maybe an interesting solution would be to just make it simple, but would that be possible? If you make it too simple and you just go with non-specific back pain or back pain, won't that generate some unwarranted uncertainty, and won't that lead people to keep on going and trying to find the second, third, fourth, fifth opinion until they hear what they want to hear, is something that gives them a little bit more certainty? It's really interesting. Thank you.
Question at the back.
Hi, sorry, need to turn that down. I'm Katie, I'm a physiotherapist in Glasgow. Just wondering, there were some benefits to the terminology of non-specific, although I think within your definition it said, I'm not able to tell you. But does the term non-specific leave us to openness to discussing more of the kind of multifactorial approach like you were mentioning with our patients, particularly when we think about these chronic pain patients who have been bounced around, been given usually various different labels and diagnosis, by using the words non-specific or something similar, not necessarily set on that, does it open the opportunity to then explore with that patient really what are the other potential driving factors, particularly with these persistent pain patients, rather than it being so structural? There might be structural influences, but discussing more openly other drivers that might start to make more sense to them, why they've maybe been to see all these different people who have done quite passive treatments potentially that haven't worked.
Yeah, I think that's a good point. I personally think that the term non-specific is the problem. You can probably do the same as you're suggesting just by using back pain, and then start talking about the multiple drivers of the condition. I do think that the non-specific aspect of it creates a bit of problem, and it doesn't help much. But that's my personal opinion. I do agree with you that we need to be able to find a term that allows you to bring up the other drivers, that we don't get stuck into that strictly structural view of back pain as merely a structural problem. I think it's an important consideration.
At the front.
Hi, Jerry. Thank you very much for a great presentation. I just would like to be the devil's advocate to Lisa's proposition to use back pain, just because I think it would give potential credit to biomedical labels where others could say, well, I know much better and I think you have sacroiliac pain. And if we had just a very simplistic explanation, it might be disregarded quite quickly. So I think there might be a bit more, considerations to take. My question was related to the labels you used. I may be wrong, but I have the feeling that maybe you didn't use behavioral labels like guarding or things like that. And I was wondering whether it might be something that could target self-management a bit better, supporting patients to see what they could do themselves to get better. And I was wondering if you had any work in the pipeline along those lines.
Thank you. I agree with your comment, and I think from the previous question, in the ideal world, I think if there was no variation in how clinicians speak to patients, then maybe go as simple as possible would be the way to go. But then again, you provide a simple explanation that your colleague next door gives this beautiful label that explains everything, and that's the issue. In terms of behavioral labels, we don't have any work in the pipeline. I do think it's an interesting proposition, though. And if there were a label, if I got it right, if there were a label or labels that can trigger positive actions, I guess that could be something to be explored.
Okay. I just want to say that being a jobbing clinician working in chronic back pain, that's my whole area, I wouldn't tend to use non-specific with a patient specifically. It might be a word that I use between clinicians to bundle up some ideas, and those ideas might be that there isn't any radicular involvement, there isn't any hip or serious pathology, and certainly from a patient perspective, we're going to be talking through what we don't think is going on as well as what we may be going on, and certainly from a cognitive functional therapy perspective, there's heaps of things that we might be looking at in terms of lifestyle, avoidance of movement. So not using a label doesn't necessarily mean that we have nothing to work with patients.
Final question?
Hi, thanks. Tim Woodacre, consultant surgeon from Derriford. Just going back to the previous point of my colleague here and yours, and your idea of disagreeing non-specific back pain as of NAS, do you not think a two-part answer here, if I can? So pain's a symptom, not a diagnosis, and yet everyone's using it as a diagnosis. And so number one, the whole non-specific back pain, how do you think we can possibly tell a patient they have non-specific back pain if all their specific causes haven't been excluded to the best of your ability? And two, in doing that, how does one go about nationally suggesting all these treatment modalities for non-specific back pain when those are treatment modalities for a symptom, not an actual diagnosis?
Thank you. Those are good questions. I think in regards to the first one, it comes back to my points in the presentation about how useful will the diagnosis be? Will that improve your understanding of prognosis? Will that help you understand how the patient is going to be like in 12 months' time? Will that lead to better treatments? And in my opinion, and I understand this might be a bit contentious, but if the answer to both questions is no, it's not going to help with any of those things, then what's the point of making a diagnosis? I do want to point out, though, that I'm talking about people who have been already examined and investigated, in the sense that serious pathology has been excluded. So now we're talking about that's probably not a good label, but ordinary back pain. The serious stuff has been already excluded. And in terms of the second question, I think this work is in its very early days. I don't think we're in a position to suggest how we should be labeling back pain globally. I think what we did was doing a proof of concept study showing that yes, different labels change people's preferences for management, but obviously a patient's desire for imaging doesn't mean that imaging will or will not happen. This happens in a clinical encounter, and the clinician will be very important in deciding whether that's a thing that should be done or not. If the patient's intentions of having imaging reduces by 1 point, and the clinician in front of me says, "Yeah, you need a scan right away," obviously, you will have a scan. So I think we need to keep having these conversations. We need to study how to come up with a way of labeling certain types of back pain that will generate less threat and that will make people more active and to achieve the outcomes that we want, which is return to work. People, not completely disabled as sometimes they are.
Great stuff. Thank you so much, Giovanni, and a big round of applause.
Thank you.